So friends, we will be discussing regarding hereditary spherocytosis. Hereditary spherocytosis, what is hereditary spherocytosis? It is an autosomal dominant disorder. And here you are going to see lots of spirocytes. So that is the key feature. You are going to see spirocytes. And the spirocytes are like spear-shaped. And spear-shaped RBCs are being seen over here. That is the characteristic feature. Normally, the RBCs are biconcave, but here because of loss of surface area, there will be the RBCs will become spherical. That is the important feature. And here you are seeing a spear-shaped RBCs. But why it happens? It is also worth noting that there is a prevalence in certain parts of the world. It is more common. So loss of surface area is much more seen in spherocytosis, and that may be variable depending upon the intensity of spherocytosis. That you need to remember. As you can see over here, the spirocytes are not flexible. That is the important feature, and they become and there is high risk for pigment gallstone. That is the key feature for hereditary spherocytosis. This is the key feature that you need to remember. And clinical features, huge splenomegaly will be seen, as we discussed already. Jaundice, there is a high risk of gallstone, and the complication, one of the complication is aplastic crisis. Aplastic generally due to superimposed parvovirus B19 infection, which is generally self-limited infection. It can lead to either a particularly crisis with red cell aplasia, or cause complete pancytopenia as well. So treatment maybe splenectomy is an important. So that may be a familial history. So if there is a familial history of splenectomy, so that is indication of that the patient may be having a familial hereditary spherocytosis. Now, clinical variants, clinical appearance can vary a lot. And some of the patients, even some of the child will be born in utero with hydrops fetalis, leading in utero death of the fetus. That is severe case of hereditary spherocytosis, or the child may present consequently with mild to moderate mild to moderate features of hereditary spherocytosis may be there. So the clinical features, all these anemia, jaundice, etc., so are quite variable. So what is the abnormality? What is the pathophysiology? So there is a lipid bilayer. Thing is, there is a deficiency of spectrin assembly that is being seen over here. So deficiency of spectrin assembly is being seen over here, and there is a complete loss of membrane stability due to this ankyrin, which acts as a binding protein between the spectrin and the RBC phospholipid bilayer. That gets distorted, and there is a spectrin assembly defect that leads to loss of lipid bilayer of the RBC membrane. So spectrin and ankyrin genetic defects are commonly being seen, and some areas in like countries like Japan and all, protein 4, and even band protein also may be deficient in area. So whenever it is being asked, so spectrin and ankyrin, both common defects. Ankyrin is regarding more common genetic defect, but again the consensus is not very clear. But whatever ankyrin spectrin gene defect is there, but ultimate thing is the defect in the assembly of spectrin. So there is a, as we discussed, there is a shear force while passing through the splenic canaliculi. The RBCs have to be quite flexible. So if that doesn't happen, the RBCs the splenic canaliculi, they are unable to pass through the splenic canaliculi. They are rigid RBCs that are, so it gets trapped, and which are cleared subsequently by splenic macrophages, leading to splenomegaly, and there is basically hemolytic anemia. So it is depicted in this animation as well. So these are the some lipid bilayer, and these are some proteins, ankyrin, band 3. So these are some proteins, and this ankyrin is the one which spectrin provides the structural support, and ankyrin is the one which integrates the spectrin with the lipid bilayer. So here what will happen? There will be anemia that is generally will be seen in all cases of hemolytic anemias. Hemoglobin mildly reduced, MCH may be normal, MCV may be normal or slightly decreased, but the most remarkable part that is often asked in your questions or vignette is the MCSC increase MCSC, and there is a reticulocyte count increase of more than 3% will be seen, and peripheral smears will show characteristic spherocytes, and there is a polychromasia, nucleated RBCs are there. Confirmation test, you can do a osmotic fragility test in which the RBCs lies at a much lower concentration of RBCs lie much earlier compared to the normal RBCs, and there is an increased lysis in concentrated salt solution. So that is the characteristic feature. Apart from that, you may do EMA binding test. So eosin dye, you can just see how it binds to the RBC membrane, and you can do a in vitro study also can be done, and further it can be quantified by flow cytometry. So how much is the defect and all. So eosin, if it is not binding to that of the lipid bilayer, so that means a defect is there by some of the binding protein is absent. So that confirms the diagnosis of hereditary spherocytosis. Apart from that, you may ought to do this direct Coombs test to differentiate from autoimmune hemolytic anemia, because hereditary spherocytes, these spherocytes will be seen in acquired cases of hemolytic anemias as well. So particularly in autoimmune hemolytic anemias where there are antibodies on the RBC surface, and also there may be a reaction and there may be spherocytes that will be seen. So in those cases, the direct Coombs test will be positive over there, and here it will be negative. So increase osmotic fragility, and here the RBCs start hemolyzing at as 0.85. So increased osmotic fragility is being seen over here, and they lies at they begin hemolyzing much earlier, and that is the characteristic feature. Mildly hypotonic solutions also they start lysing. That is the characteristic feature, and they imbibe water, and they are more prone for lysis compared to that of the normal RBCs, which generally lies at 0.5% of salt solution. So as you can see, RBCs lies much earlier, and here, as you can see over here, there are spherocytes that are being seen. So these concentrated small RBCs, rounded RBCs, these are spherocytes, and they have lost the central pallor. This kind of images may come in your questions. So being lost, and there is it's very darker, so MCSC is higher. So this is the characteristic feature. Apart from that, you may see nucleated RBC, some polychromasia, as you can see over here. So polychromasia that indicates increased retic count. These all features will be seen, and this corresponding to hemolysis, you will see there is a decrease, there is increased LDH and altered haptoglobin may be seen in blood in measurement. So that is another important feature of this hemolytic anemia associated with hereditary spherocytosis. So hope everything was discussed in detail and all things are cleared in hereditary spherocytosis. If you have any particular question, you can just ask me. Okay, in case there are no questions, so I would like to end this live presentation and hoping to have more interaction and announce in advance so that you can attend the sessions. This will be a regular thing now onwards, and we'll clear all the important topics one by one. Thank you. Thank you for attending, and happy Navratri and happy Dashera to all of you. Bye for now.